Perfect. Okay. So I started the recording. Okay. So now we have the first lecture or first session in our third season of PharmaFree. I believe this season will be a little bit different than the other two seasons that we had already. Okay. So we will have like a mix of the last two seasons. Okay, we will have an explanation. We will explain the diseases and etc. From different resources. Actually, it's not only from the CTC. We try to incorporate other resources as well in our material. Okay, this is the first good thing that we have. The other things, we will have interactive sessions. Okay, so it will not be only like, yes, it will not be only monodialoguing or unidirectional sessions. Okay, we will have to interact together. We will have questions, we will explain, and etc. If you will have any questions or something that's not clear, you are totally free to post it in the conversation chat or the chat room that we have. Okay, just I will keep it in front of me all the time. Okay, so whenever you have a question, feel free to share it here in the, do not unmute yourself unless I requested you to do so. Okay, so just write the question you have and I will see it at once. Okay, I can see here that we have most of the colleagues were attending with us from in the last season, season 2. I can remember Ahmad Tantawi, I think, Armia, of course, Leah, ناجح طبعا, Noha Al-Kholi, Rashmi, Samar Kassab, yes, and we have some other new colleagues as well. Welcome to you all on board, and we hope that we will have a valuable sessions and a session that would have benefit to all of us. Okay, and excuse my English language. Okay, it's not 100% perfect, but I will try to explain it. So let's start with the ADHD. Today we will have 3 topics actually: ADHD, and we have depression and anxiety. Tomorrow you will have another session, I think, with my colleague Ayman. He will address the psychosis and OCD, and I don't remember the other topics, but he has like 4 topics or something. Okay, so for the ADHD, I can, مش عارف أنا ليه مش شايف الشات room. Where is the chat room? I cannot see it. Yes, now I see it. I saw, yes. Sarah's saying, can you keep the old lecture, please, for us to review? I didn't really listen to them all. They have explanation for the question. Yes, of course. We will do it. Okay. Shamsi, you will keep the season 2, right? Perfect. Thank you. Thank you, Rashmi. Okay. Yes, we will keep season 2. Okay. So let's start, my friends. Let's start with the ADHD. Okay, ADHD is it's not one of the most common, it's the most common. Okay, infantile disorder, I think, in Canada. Okay, if you are working in a pharmacy or something, you will see that about 80% or 75% of all the prescriptions that come to your children population in the pharmacy contain at least one stimulant. Okay, contain one stimulant at least. It's by far the most, from my perspective, it's by far the most common infantile disorder at all in Canada. Okay, it's very common in Canada. And I believe this is because of the screening. Now, as you know, if you have children in school or something, you will see that they have an annual or biannual screening to all the schools. They have the criteria. They examine the children at the age of 6 years old and above for the ADHD symptoms. Okay, that's why I believe this is one of the most relevant reason. That's why we have like a breakthrough in ADHD diagnosis in Canada recently in the last 5 years or something. Okay, uh, as we all know, uh, we have three hallmark symptoms or cardinal symptoms to ADHD. We have hyperactivity, impulsivity, and both of them constitute the first arm of ADHD, which is usually hyperactive and impulsive subtype of ADHD. The third hallmark symptom is inattention. Okay, so we have inattention in one arm. On the other arm, we have hyperactivity and impulsivity. Okay, and what about the most common subtype of ADHD? It's the mixed or combined subtype. Okay, usually when you have a children in the pharmacy or something, you ask her mother or his father about the symptom he has. They would say he's very nervous all the time. He's hyperactive. He cannot sit for a long period, like for even for 5 minutes or something, and he lacks he lacks of concentration. Okay, he's not concentrating as at all. Okay, so usually the two arms are present in the same setting, the inattentive and the hyperactive or impulsive behavior. Okay, so as we said, this is the most common. For the diagnosis of ADHD, we are not so much like a pharmacist concerned about that, but you can see all the criteria in the CTC. In your CTC, if you check, you will find, the criteria of the 6 items and etc. This is exactly the thing. Okay, I can, yes, here it is. It's according to Diagnostic and Statistics Manual, number 5, criteria for diagnosing ADHD. Okay, you can read them. Okay, but usually you have, as we said, we have the first subtype, which is inattentive ADHD, the other subtype, which is hyperactive or impulsive ADHD. Okay, you can read all the criteria here, but as I said, as a pharmacist, we are not so much concerned about that, about the diagnosis. Okay, but it's important to know that not every children should meet this criteria to be diagnosed with ADHD. Do you know that? Have you ever heard about the ADHD excuse me, a children with ADHD who meets the criteria, and the children patient with ADHD who doesn't meet the ADHD criteria? Have you ever heard about that?
Doctor, can I speak, please? Can I
Go
ask
ahead,
you a
Armir.
question? Okay.
Your voice,
What?
your voice
Okay.
is too low, Armir.
Okay. This is okay now, like that.
Yes, my friend.
Okay. What I know, that is the criteria of ADHD, and you can correct me if I am wrong. It is we have the to diagnose the child to have ADHD. We have the symptoms in two settings, in the home and the school, and for 6 months.
Yes, okay. This is the criteria, Armir. You are talking about the criteria now, correct?
Yes.
Okay, but not every children should meet the criteria to be diagnosed with ADHD. Okay, in Canada, if you look, you just check here the criteria. What is the criteria we have? The children should meet 6 of the following symptoms, right? For at least 6 months to a degree that's consistent with development level. Okay, this is the criteria that we have according to the cadre, I think. Okay, one, two, three, four. The children should meet 6 of them. What if the children meet 4 from that and 3 from that, and the physician is totally suspicious about the ADHD? How can we proceed here? Do we ignore the situation, or what we should do? What should we do here? What do you think? Because you will, if you
We
search
can.
about that, you can see that ADHD with criteria and ADHD without criteria. Okay,
Okay.
what should we do? Do you have any idea? Does anybody
Yes,
know?
yes, I can tell you if the children meet some of the criteria, not all the criteria, we can begin with the non-pharma with him.
Yes, perfect. Good strategy. Yes, we can start with the non-farm technique here. Okay, if the children is not 100% meets the criteria of ADHD, what we can do, we can start with non-farm technique. Okay, I will tell you what we can do now. What about the non-farm technique? But this is like a one slide for the cadre. It's a definition of the cadre, and it's very important to know to recognize the name. Okay, cadre is the entity or the body that is responsible for, which is most appreciated here in Canada for the ADHD. Most of the physicians, or if not all of them, are following their guidelines and diagnosis and etc. Okay, so cadre is very important. Just recognize the name. Okay. Okay. Yes, we are still in the criteria issue. Here you have the criteria. This is the criteria from the Diagnostic and Statistics Manual 5, number 5. Symptoms persistent of 6 months. This is number 1. Symptoms were present prior to age of 12. What do you think? Do we all follow this criteria? What do you think? What about if can anybody develop ADHD after the age of 12, like at the age of 20, for example?
Yes, yes. There is
Correct?
yes,
Yes.
there is ADHD for the adults, but it's a little bit different for the criteria from the children.
Yes. And here you have the note. I put a note here. This is from the CTC, yes. There is emerging evidence that ADHD may occur in young adults with no childhood diagnosis. The prevalence of ADHD in adults is about 3 to 4%. Okay? So it's not only, this was like in the past, yes. The children or the patient should had developed one or more symptoms of the ADHD before the age of 12. But now, even if you were 100% healthy or mentally healthy in your childhood, you may still develop ADHD in your adolescence, for example, or during your youth, or even in, I think in your 50s. We have, yes, I met once, but only, actually, it was only once. I met a patient who was 53 years old, and he has just been diagnosed with ADHD. And it was really bizarre for me. But yes, as we said, due to the screening, the broad screening, and the advances in the terms of the screening and the diagnosis of the ADHD, the cases are increasing. Okay. But what about the hallmark of ADHD in adults? Here's a small note.
Excuse me, this adult hyperactive adult or just not concentrated?
Not concentrating. This,
Yeah.
yes, we will talk about that right now.
Okay. Okay. Thank you.
It is not hyperactive. It would be really strange.
Yeah,
Okay.
I know. Mainly in adult, it will be loss of concentration or loss of attention. So that's why I'm
Yes.
asking. Yeah.
Yes.
Thank
And
you so much.
usually, by the way, usually it comes with a depressive mode or something. Usually, it's not. If you see an adult with ADHD, you will find him take like you will find him that he's taken like benzodiazepine or antidepressant or something. Because usually it comes with depressive mood or with other psychotic, other psychiatric condition.
Yeah, but
Okay,
actually, all of us now need ADHD medicine to more concentrate. I think
stimulant.
so.
We need stimulant. Yeah. Okay. So here's the other criteria. Symptoms interfere with reduce the quality of life. Yes, this is one of the most important criteria here. Why we give medications? Why we give pharmacological treatment to the patient, either children or an adult? It's for that reason, to improve the quality of life and increase the academic functioning or the work conditions and etc. Okay, if the ADHD is not interfering with your daily life activities, so no need to take a medication. Okay, that's it. Okay, perfect. So let's proceed with adults. As our colleague said, primarily it's inattentive subtypes. Okay, this is the most common in adult ADHD. But however, we can say that there is very small percentage that may have impulsivity or hyperactivity subtype, we don't know. But usually loss of concentration, inattention, and loss of interest to do like mental activities or something. This is usually the most common symptom that you may notice in an adult ADHD. Okay, let's come here to one of the, no, this is an important part actually, the non-pharmacological choices in ADHD. Okay, perfect. So can we give non-pharmacological choices alone in any age group with ADHD, or we cannot? Can
No,
anybody?
we cannot.
Yes, you
Okay,
can if it is a mild case. We can if it's a mild case. You can monitor it. If it is,
the mild case.
yes, if
What
it
do you
is
mean by mild case?
okay, if it is a child meet only some of the criteria, not all of the criteria. Besides, there is no impulsive action. There is no in his behavior. It is not impulsive. It is not aggressive. So we can start with non-pharma and monitor it. Monitor him.
Okay, what about the effect of the non-pharm technique on the core symptoms of ADHD?
I think non-form is not helpful as a monotherapy. It's only for to improve the sociality of the kid. It will help only to improve his sociality and self-esteem only, but it can't help as a monotherapy.
Yes, usually non-pharm technique, okay, has minimal or least effect on the core symptoms of ADHD, okay, like impulsivity, hyperactivity, and inattention. Why we use the non-pharm technique? Why we use it? First of all, let's ask a question. What type of therapy we use usually in non-pharma technique? Do we use the psychotherapy or do we use behavioral therapy? Do you know
Behavioral
the
therapy.
difference? Do you know the difference between both? behavioral and psychotherapy. In ADHD, you said that we use behavioral therapy, right? Correct?
Both of them.
Yes.
Hmm. Both of them?
Yeah.
Okay. Usually behavioral therapy, we use it to in ADHD. What does it mean? I will explain now. But for psychotherapy, we use it usually in an anxiety and depression and any psychiatric disorder, any other
So maybe
psychiatric.
we gonna use a psychotherapy with the adult because it might be combined with depression
If
if it
if
yeah
it's combined with
yeah
depression, we can use it. Okay,
okay.
like the CBT. What CBT is it? Behavioral or psychotherapy?
Cognitive behavioral.
Yes, it's psychotherapy. Okay, so behavioral therapy we use it here in the ADHD. For what reason? Do we use it for the children or we use it for the caregivers?
I think both of them we have to give it to a caregiver and the child and the teacher as well.
Yes, usually with the behavioral therapy, it's very important to educate the teachers and the parents, okay, to start know how to deal with this patient. Okay, so the most important here in the ADHD, psychotherapy has nothing to do here. What we do, we give behavioral therapy. Why we give behavioral therapy? Because for the patient, it's very important to know how to behave, to deal with him. How the patient, how can I behave this patient? How can I make him more disciplined like that? Right. Okay. So the behavioral therapy is mainly dedicated to the parents and teachers. Okay. Psychotherapy, if we ever decided to go for the psychotherapy, it's mainly designated to children or to the patient. Okay, this is one of the main differences between behavioral therapy and psychotherapy. Psychotherapy, we use it, as we said, for the other psychiatric disorder like depression, anxiety, and etc. Behavioral therapy, we use it for ADHD, not for the children mainly, but for the teachers or the caregivers or the parents and etc. Okay, while the psychotherapy, as we said, it will be designated to the children or to the patient. Okay, that's it. When can we use the non-pharma technique as a first line of therapy or first line of treatment? Can we ever use the non-pharma technique as a first line of treatment? Yes, we can. In what setting? Do you know? In what setting can we use the non-pharma technique? Have you attended the season 2 sessions, my friend? We'll say we asked some question about that in season 2.
Might be under 6 years old.
Yes, exactly. Leah and Rahaf. Perfect. Yes. Preschool age. In preschool age, yes, we can give non-pharma technique as the only option that we have, unless the patient has severe symptoms. Severe symptoms. He's very hyperactive, he's very inattentive, and etc. In that case, what we should do? If the patient is 5 years old or 4.5 years old and he's very hyperactive and very inattentive, and he's making a lot of troubles on the problem, what should we do? Should we try only the non-pharm technique?
No, we should combine with therapeutic pharmacological therapy.
Yes. In that case, we can give therapeutic or pharmacological treatment. Exactly. Okay. That's it. You know, there are always exceptions, my friend. There are always exceptions. It's risk benefit. If the patient interest comes first. Okay. This is a practice. This is a medical practice in general in Canada. Okay, you make your judgment, you make your decisions, and you should respect the rules and the regulations. Yes, but at the end of the day, you are a healthcare professional that you have to make your judgment that pours into the patient's interest at the end. Yes. Can we use neurostimulant? Yes, we said yes, we can. Who could be involved in non-pharma technique and non-pharmacological therapy implementation? As we said, parents, teachers, other caregivers. Okay, perfect. Yes,
العفو
management.
دكتور تسمح لي السلام عليكم.
Yes, go ahead.
Sorry, just I want to ask this lecture, which time we can see it in the recorded?
Yes, I think it will be recorded and uploaded within 1 or 2 hours, maybe after the
In the same day.
I think yes.
Okay,
If
perfect.
Shams
Thank you.
can correct me, it would be fine. If no, though, I think it would be right.
Thank you very much.
Usually in the same day, yeah, on the same day. Within 24 hours, it will be uploaded. Okay, and as we said, we will keep season 2 lectures as well. Okay, so here it is. This is one of the most.
Which neurostimulant we can use for preschooler?
Which neurostimulant we can use?
Yeah, which one? You said non-pharm plus drug. Which drug we can use for preschooler?
Yeah, you can use. Yes, this is very important point. We will discuss it now. But
yeah.
Here, let's talk about this. No or minimal effect on ADHD core symptoms. Keep that in mind. Non-pharma technique in ADHD, no or minimal effect on ADHD core symptoms. Okay, this is very important. That's why we do not recommend non-pharma technique for most of the patient or for alone. We do not recommend it alone. Okay, let's address the question of our colleagues. Our colleague, she asked what agent we can use in preschool age. Do you have any clues? Can we conclude what agent we can use? If we have a patient who's 5 years old, he's 5 years old, and we want to give him like a new stimulant. Yes.
Methylphenidate.
Why? Do you have any rationale for that?
No, I see. It's dispensed in the pharmacy so much frequent. That's why.
Okay, so you want to give him Concerta, right?
Yeah.
Okay, so this guy is 5 years old, and Concerta, are you going to crush it? Are you going to give it in the whole form so he can swallow it, or what?
I think swallowed, because as I recall, Concerta cannot be crashed. I'm not sure.
Okay, so you are going to ask a 5 years old kid to swallow a Concerta tab every day, right? Is this logic?
No.
Okay, so what should we do here?
Might be the osmotic, we can give him the osmotic tablet.
Osmotic tablet? Osmotic tablet Concerta, my friend. It's a Concerta. Okay, we will address that now. Okay, let's start by the agent that we have here. Keep that in mind. We have 4 agents or 4 molecules in Canada for the ADHD, like a neurostimulant. I'm talking about the neurostimulant, okay? Not about the atomoxetine. Yes, we have atomoxetine and we have the alpha-2 agonist, but here I'm talking about the 4 neurostimulants, okay? Yes, Amgad is saying we should investigate options with the syrup or suspension preparation. Not sure which of this. Okay, no problem. Okay, so let's start, my friend. Uh, this is okay. Here we have four options, right? Dextroamphetamine, less dexamphetamine, methylphenidate, mixed salt amphetamine. Okay, can you tell which one of those are long acting and which one is intermediate or short acting? Can you tell? Do you have any clue?
The list this amphetamine is short acting.
You killed me, my friend.
Okay, sorry.
You killed me. Less dexamphetamine is short acting?
Less dexamphetamine is less dexamphetamine. It is given. Yeah, it is intermediate acting. It is.
What is the brand name? Okay, to facilitate your lives, guys, let's start one by one. Dextroamphetamine, the brand name here is Dexedrine capsule. Okay, if you can write it or anything. Dextroamphetamine is the Dexedrine capsules, and it is intermediate acting. Okay, dextroamphetamine, it's intermediate acting. What does it mean, intermediate acting? It means that we have to give it twice or three times daily, for example, right? That's why dexedrine is not dispensed so much like or so frequently like the other options. Dextroamphetamine, okay? So do you have any idea, is dextroamphetamine, is it first or second or third line of treatment for ADHD?
We're writing it as a first line from the
First.
slide.
Yes, it's first line, right? What, I cannot see your name, excuse me. What's your name, Mohamed? اسمك ايه يا باشا? What's your name? أحمد طنطاوي؟
أنا أحمد.
طيب مش شايفك أنا بس مش شايف الأسماء معلش I'm sorry.
لا.
Okay. Okay. So dextroamphetamine is intermediate acting. Yes, but it's not first line. The first line is long acting neurostimulant. Dexedrine is second line. Okay. Dextroamphetamine, intermediate or short acting or intermediate or immediate acting, they are second line, not first line anymore. The only first line are the long acting. Okay. Second one is less dexamphetamine, and the brand name is Vivance. Vivance. Okay. It's important to recognize the name, by the way, just to make it easy for you. Okay, Vivance is less dexamphetamine and it's long acting and it's first line. For dextroamphetamine, can we open the capsule and sprinkle it over the yogurt or sauce or anything? Can we do that, or the children should swallow it as it is?
I think should swallow it as it is because it's a immediate release
No,
or
no,
sustained release
no,
of X.
no, no,
No?
no, 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 no. Yes, we can open it. We can sprinkle it over like yogurt or whatever, or even you can mix it with water, okay? And he can swallow it. So this seems to be a good option for 5 years old children, right? Because yes, we solved the problem of the swallowing, correct? Okay, let's go to the second molecule. As we said, this is Vivance. Vivance is less dexamphetamine, and it's long-acting one, okay? And it comes in capsule form. Of course, it's first line, because as we said, long-acting are usually first line, short or intermediate acting, they are second line, okay? For Vivance, can we open the capsule and sprinkle it or no? For the Vivans, it's long acting, right? Can we do it or no? Leah says no. Rashmi says yes. Okay, I would agree with Rashmi. Yes, Vivans, yes, we can open it. Okay, we can open it, we can sprinkle it over any food, and we can mix it with water. Okay, so we have here a first line option. We solve the problem of the open the capsule and etc. And so it would be convenient to 5 years old children. Okay, so less dexamphetamine is the Vivans, and yes, long acting and can be sprinkled. Let's come to the methylphenidate. Okay, how many forms we have for the methylphenidate?
There is two forms, البايفنتين والكونسرتا.
Do we have any other form? And they are long acting, intermediate acting, short acting.
Both are long acting.
Okay. Do we have any other form? Yes, we have the Ritalin, Ritalin SR. Okay, and this is the intermediate acting. So we have Concerta, we have Bifenthine, and we have the Ritalin. Ritalin is the intermediate acting, which should be administered 2 or 3 times daily. And that's why it is first or second line. Of course, it's second line. It's a second line. Yes, the Ritalin is second line. Concerta and Bifenthine, they are first or second line. Hmm? What line? First or second line?
First line. The long acting, it's first line.
ماشي الله ينور. Yes. So Concerta and Bifenthine, they are first line. Okay. Perfect. So regarding the swallowing problem, Concerta and Bifenthine and Ritalin, can we open them or should we swallow them as they are? If you can answer this question, I would give you $100.
I think
الكونسيرتا ما بتتجزأش.
بالظبط. You remember that. الكونسيرتا زي المبادئ. الكونسيرتا ما بتتجزأش. Yes. What? Okay. So all of them cannot be crushed, right? Cannot be open. Leah says can open. What you can open? Okay. So here, guys, Concerta is tablet, right? Bifenthine is tablet or capsule? No, it's capsule. Okay. Bifenthine is capsule. Bifenthine, we can open it or no? One word. Yes or no? Yes or no? It's long acting, okay? It's controlled. Yes or no? Yes, we can. We can يا شمس. We can يا أمجد. Yes, Ziyad and the hand, yes. We can open the Bifenthine and we can sprinkle it and etc. The Concerta, we cannot do it. For the Ritalin, yes, we can do it. Okay, for the Ritalin as well, yes, we can open it and etc. Okay, perfect. That's it. Yes, Shamsi, yes, I know. Go to the last page. Yes, we have on the last slide, you will find all the summary of the medication. We will go through it, no problem, don't worry. Okay, perfect. Ritalin is which one? Ritalin is methylphenidate intermediate acting. Okay, guys, for methylphenidate, we have three brand names. We have Concerta, which is tablet, and cannot be dispensed, cannot be crashed, excuse me, and cannot be crashed. The other one is the bifentine, with that comes in capsule form, and it's long acting as well, and we can open it and sprinkle it. The third one is Ritalin, and it's intermediate acting, and we can open it as well. Okay, this is for the methylphenidate. Yes, exactly, yes, Sarah. Shukran jazaak. The last one is mixed salt amphetamine, which is the brand name, one of the most famous medications here, which is Adderall XR. Adderall XR, mixed salt amphetamine, and it is long-acting medication, and it comes in capsule, I think. Yes, it comes in capsule, Adderall. I think yes, it's capsule. I don't remember actually, but yes, I believe it's capsule. Okay, so Adderall, do you have any clue? Can we open it or no? Can we open it? And yes, yes, بالظبط. Yes, yes, yes. I believe you all. Yes, for the Adderall, yes, we can open it or we can sprinkle. Okay, so these are the four molecules that we have here in Canada: dextroamphetamine, lisdexamphetamine, methylphenidate, mixed salt amphetamine. Okay, I think they are clear. We cannot repeat them all, but you can rehear the recording and you will find out what we say. But this classification, just remember the brand name because it's very important and would really facilitate your lives. Okay, it will make the things easier for you. Okay, here we have a reminder like, yes, all of us know that stimulants are drug listed in part 1 of Schedule G of the Food and Drug. Written, yes, we can take it verbally, written, faxed, prescription. We can give refills only with written prescription, not with verbal ones. Total quantity to be, yes, and etc. We have a case scenario here. Yes, it's a good one. Let's discuss this case scenario. Okay, be focused, my friends. Can you see the case scenario? Can you see it? Can you see it or no?
Yes, we can see it, yes.
Recording in progress.
Perfect, my friend. طيب يلا بينا. Let's start. Can anybody read? حد يقرا يا شباب؟ Can anybody read?
Doctor, please,
Yes.
before we start in the case,
Armia, you have a problem in your voice. Please, you can write in the chat room.
it's okay now? You hear me now?
Yes, but please, you can write in the chat room if you have a question or something, because we have to proceed at the same time. We have
Okay.
2 more topics to address. Okay.
Yes.
Thank you, Armia. شكرا يا باشا.
Thank you, sir.
Okay, so guys, we have a lady whose name is RF. She is 21 years old. Please mute your voice, my friends. Okay, she's 21 years old, female, comes to pick up her 30 milligram V-Vans, which is lisdexamphetamine. Your technician refused to serve her because she has already 7 capsules of 20 milligrams remaining from last month's pickup. Upon questioning and reviewing the original prescription, RF says we need the 30 milligram. There's an echo, guys. Armia, can you mute? Yes. I muted you, Armia, معلش. RF says she needs the 30 milligrams because of her inability to concentrate as it should be on her studies and exam. In the original RX, you will find that the doctor note, take 10 milligrams for 7 days, then increase to 20 milligrams for 7 days, then stay with it or increase to 30 milligrams if well tolerated. Mete 30 capsules every 30 days. Total duration of treatment is 3 months. Okay. First service was 40 days ago. What would be your most appropriate action? Okay, so the situation is the lady came to pick up the first week of 10 milligrams, and then it came for the second week and picked up 1 week for the 20 milligrams. At that time, she decided to stay with the 20 milligrams for 1 month. But before 7 days, before the end of that month, she showed up in your pharmacy asking for the 30 milligram Vivans. Okay, is it clear? Your technician refused to give her the 30 milligrams because she still has the 27 capsules of the 20 milligrams at home. Okay, this is the situation. Is it clear? I think yes, it's clear. Perfect. So first question. What would be your most appropriate action? Dispense here. One moment, I have to add a question. Just one moment, please. Can you see the screen? شايفيني يا شباب على السكرين؟ سوري يا شباب. سوري يا شباب، حد دخل الأوضة مرة واحدة. Okay, here we go. Type, let's go. What would you do? Dispense her the 30 milligram for 7 days. Advise her to wait for the remaining 7 days with the 20 milligrams so you can dispense the 30 milligrams. Fax the prescribing physician for authorization. Dispense her 7 capsules of the 10 milligrams to be taken with the remaining 20 milligrams she has. Okay, so you have a prescription and you have that. What would you do? Irini said D, Leah D, Rashmi C. What do you think for the others, for the remaining colleagues? What do you think? Sarah says B. Latifa C. Okay. 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 Tantawi A. B. Okay. Okay, it's enough, my friends. It's enough. Okay. What's the problem here? We have no problem here, right? The problem, from your perspective, that the problem is she has still 7 capsules of the 20 milligrams. Okay. And if you give her the 30 milligrams, she would have 50 milligrams, right? Correct? That should be fine? No, it shouldn't be fine, because she said that she's not concentrating and she needs to concentrate because she has exams and etc. So spontaneously, she may take the 2 tablets at the same time, the 30 milligram and the 20 milligram, right? So you can put her at risk here of overdosage or something. This is number 1. Number 2, advice here to wait for the remaining 7 days. No, it's not logic. So she needs the 30 milligram now, and she has a prescription for that. Okay, it's not logic to tell her wait for 7 days and I will give you the 30 milligram in 7 days. No, okay, it's not logic and it's not in the patient's interest. Fax prescribing physician for authorization. Why? Do we need any authorization, Latifa?
No, she's already having her prescription.
Yes, she has a prescription. Why would you fax? What would you say for the physician? What would he reply you? He has nothing to say, and you have nothing to say as well. Neither. Okay? So that's it. The most appropriate one is this one. Yes, you can give her the 10 milligrams for 7 days to be taken with the 20 milligrams she has. So you will give her the full dose, the 30 milligrams, right? Which is the prescribed dose. And there is no problem here because you have a prescription, you have the authority to increase the dose to 30 milligrams, to 30 milligrams. Okay? So no problem at all. Yes.
بس ثواني هنا معلش. I think إنه هو البريسكريبشن أصلا هو كان قايل لها تمشي أسبوع 10 وبعدين أسبوع 20 وبعدين تطلع ل 30 لو محتاجة، فكون إن هي معاها 7 كبسولز من ال 20 يعني هي ما خدتش الأسبوع اللي فيه 20 أصلا.
No, I didn't say that. I explained that in the beginning. I explained that. I told you what? I told you the first service was 40 days ago. So what I said, she came to pick up her first 7 days of the 10 milligrams, and then she came to pick up the second 7 days of the 20 milligram. Then she decided to have 1 month of the 20 milligrams, right? She decided to stay with the 20 milligrams. I said that. I explained it, right? So she's actually taking the 20 milligrams. Okay, this is clear. Right? So the answer would be perfectly so the answer would be D. Okay, this is the right answer. Okay, the other question, the next question, excuse me. 1 month later, RF decided to stop the VVANs. How should she proceed? She decided to stop the VVANs. How should she proceed? Can stop it abruptly with no problem? She should taper over 3 to 4 weeks. Should see here doctor for re-evaluation. Duration of treatment is too short to evaluate the efficacy of VVANs. Wally is saying C. Sarah is saying B. Irini C. Noha D. Leah D. Yes, 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 yes. Perfect. Thank you, my friends. Thank you, my friends. None of you is correct. None. Okay. What is the duration of treatment here? She take it for 40 days, and after 1 month, she come to say that I would like to stop the medication. So for how long she's been taking the medication? For 2.5 months, right? Yes, 2.5 months. Yes, correct. And she decided to stop it. What about the dose? Is the 30 milligram, is it a high dose or intermediate dose or low dose of the VVANs? This is the first question. The 30 milligram. What do you think? Is it a high dose? What is the maximum dose of the Vivans? Of the less dexamphetamine. Less dexamphetamine. The maximum dose is? No. No. Yes, يا طنطاوي. 60. Maximum dose is 60. And you give her 30 milligrams. This is number one. So this is not a high dose. Number two, it's written clearly in the CTC. You can stop the neurostimulant abruptly if the duration of treatment or the duration that the patient is taken, during which the patient is taking the neurostimulant, is less than 3 months. If it's 3 months or less, you can stop the medication abruptly, no problem. Okay? So here we have a low dose and we have a short duration of treatment. So yes, she can stop it abruptly, no problem. Is it clear? واضحة? You got it? Less than 3 months of the sun in the CTC. Okay, perfect. So it was a little bit a tricky question. Okay, perfect, my friends. Let's proceed. What happens if the duration exceeds 3 months? What are the risks? Yes. What if the patient is taking the Vivans for a long duration of treatment? How can we stop the Vivans? Can any colleague answer, please? Let's say the patient RF it's been like 6 or 7 months. She's been taking the medication. How can we stop it? Can you answer?
Should we taper it through over time, 3 months or something like this?
Excuse me, can you repeat?
I think we should taper it dose on a period of 3 months to 6 months.
Yes, exactly, yes. We should taper it, yes, exactly. For what reason? To avoid the withdrawal symptoms, يا أمجد. Okay? Any medications that's working on the CNS or the neurotransmitters, you should stop it gradually by tapering technique over 3 weeks or 4 weeks, like that. You should decrease the dose gradually to avoid the withdrawal symptoms. Okay, that's it. Perfect. Is it clear, Yamo Amgad? Here we have stimulants versus atomoxetine duration of effect. I think it's clear for all of us. One moment, guys, excuse me. Okay, let's proceed. I think this is clear, and we repeated several times that stimulant needs about 2 to 4 weeks to give an effect, but usually the improvement in symptoms start within the first week. Okay. For the atomoxetine, it works more like an antidepressant. Okay, so it may take a longer duration of treatment, 6 to 12 weeks. Okay, that's it. This is the difference. Stimulant release differences. Yes, here we have immediate release, and we have sustained release, and we have extended release. Duration of treatment, as you say, the duration of action, excuse me, 4 to 5 hours, 8 for the intermediate, for the IR, intermediate immediate release, 8 to 10 hours for the SR, 12 to 14 hours for the ER, okay, for all of them. Okay.
هو intermediate, which one of them? Sustained? Intermediate?
Yes, it's the SR. SR is the intermediate. Okay, intermediate is the SR. Long acting or the XR, which is the extended release. Okay, that's it. For the referring to the atomoxetine, my friends. Yes, can you mention one or two differences between the atomoxetine and the neurostimulant? Can you remember one or two difference?
الاتوموكستين مش controlled drug. It's not a controlled drug. الstimulant controlled drug. الاتوموكستين most of action triple الstimulant.
Most of action what?
بيبقى triple، يعني بياخد من 6 ل 12 أسبوع أكتر من الستيمولانت، يعني محتاج وقت عشان يديني الأكشن بتاعه.
Longer duration of action. Yes, longer duration of action. Yes, correct. Yes, that's it. Perfect. Very good. Trial duration. Yes, regulation. Perfect. As we said, atomoxetine, it works more like an antidepressant. So if a patient has depression, what would be better? We give him the neurostimulant, we give him atomoxetine. What do you think?
Sorry, say it again.
If a depressive patient, we have a depressed patient, would we prioritize the neurostimulant or the atomoxetine?
Atomoxetine.
Atomoxetine.
Right. Okay. If substance abuse patient, if the patient is addicted to any other thing,
Atomoxetine.
Atomoxetine as well. Okay. Perfect. Do you remember the slide from the season 2? I will show it to you now. Yes. Where is it? Yes. Yes, this is a slide from season 2, and we have questions as well. Yes. ADHD in adults. You will find it, and here it is. You will find the algorithm. I love this algorithm actually. Okay, this is for the choice, how to choose the treatment for the ADHD in adult. Okay, this algorithm was extracted from up to date. Okay, if you find the patient here, there is a risk of substance abuse or something, or depression, you go with atomoxetine, treat with atomoxetine. You try to avoid the neurostimulant here. Okay, so substance abuse, atomoxetine. If depression, you can go as well with bupropion. Okay, bupropion can be used in ADHD, correct? Yes, we can use it.
Because it works in norepinephrine.
Yes, and with other one, there is another one, which is
venlafaxine.
Yes, venlafaxine as well. Bupropion and venlafaxine are the most used antidepressant in the ADHD. Okay, so we try as much as possible to avoid the neurostimulant with the depressed or substance abusers. Okay, substance abusive patients. Okay, if no substance abuse, if no depression, you can go with amphetamines and etc. Okay.
في سبب تاني، لو البيرنت رفضوا الستيمولانت ممكن ابدا بالاتوموكستين. لو البيرنت رفضوا الستيمولانت، صح ولا لا؟
Yes, you can start. Okay. Can atomoxetine be used with bupropion? Yes, you can use them both together, no problem, but you still have the risk of serotonin syndrome. But yes, it's not contraindication. You can use them. You can use them together. Okay. Okay. Case scenario. This is like a simple case scenario, not like the previous one. Let's say we have a child who goes to school. If he takes SR, it will work only for 8 to 10 hours. That means once he gets home, he has to take immediate release so he can do his work. That case happens with Ritalin, but not with Concerta, Pifantine, Adderall. They have effect of 40 hours. They cover the school time. And okay, it's not a case scenario. It's like yes, it's like yes, nothing to say. Okay, side effects, and this is important. You have 4 levels of side effects, as we said previously. Cardiovascular effect, and this is the most common and most apparent side effect. Heart rate and blood pressure. Yes, both will get elevated, blood pressure and heart rate, and this is normal, and that's why we go very gradually and smoothly with the dose. Usually we adjust the dose, the neurostimulant dose, according to what? According to weight or according to what? For the neurostimulant dose. How can we adjust it? Why the doctor say adjust it?
هي المفروض إن هو بيبقى تركيزات ثابتة، يعني 18 36 54 ده الكونسرتا تقريبا، إنما
Okay.
according to weight هو الأتوموكستين.
Yes, exactly. According to weight, the atomoxetine. Okay, but how can we say, you know what I mean? How can we adjust the dose? Based on what? Based on what we can give this patient the 20?
Improving of the symptoms.
Hmm?
Improving of the
Improvement.
symptoms.
Yes. So efficacy, right? This is number one.
Or response.
Response, yes, efficacy. Do you have any other criteria?
The dosage
Side
form.
effect.
The dosage form.
No, we do not adjust the dose according to the dosage form. Okay, usually we adjust the dose according to the tolerability and the efficacy. Okay, based on two. You start with the lowest dose usually, and you start increase the dose according to the tolerability and the efficacy. If the dose is not tolerable, you can stay with the same dose for a while, like for 2 more weeks. Then you can try to increase it again, and etc. But both are important.
You mean
Tolerability and
you
yes.
mean we start with the lowest dose? You mean the immediate release or long acting?
What is the first line?
Long acting.
Okay, so we start with the second line or the first line?
Okay, so just because I read a case yesterday, so the answer was from comprehensive folk. The answer was to start with immediate release first because he didn't has any other problem. So the doctor preferred to start with immediate release. That's why I'm asking: is it a old copy? Or,
No,
yeah.
usually we give the long acting, unless the symptoms are not severe. If the symptoms is not severe, or it happens only during the morning time or specific time during the day, you can give the intermediate acting neurostimulant. Okay, but usually no, we give the long acting. By default, no, we give the long acting. We do not give the intermediate acting. Okay, they are the first line. Okay, so we adjust the dose according to the efficacy or response and the tolerability, as we say. So cardiovascular, heart rate and blood pressure, yes, it's very important to monitor. during the first year of treatment or for 6 months of treatment more frequently. Psychiatric effects, hallucination, and bipolar disorders, and etc. Yes, it can happen. They can happen, but it's very, very rare, I think. Okay. Effect on growth, yes. For children, definitely, yes, they may. And it should be monitored as well. Priapism in male patients, it can happen like a side effect from the neurostimulant in male patients, male children. One moment, guys. Okay, guys. So that's it. These are the side effects. It's very important to know how to monitor, what to monitor, and when to monitor. Okay. So let's say that you have a newly prescribed patient with a neurostimulant. What counseling points you would give him? What would you say? If you have a patient with a new prescription for a neurostimulant, and you as a pharmacist would like to give him a counseling, and this is your first line job as a pharmacist, you counsel the patient. What would you say here?
If you lose more than 10% of your weight, you have to go to the doctor. You have to follow your heart rate or measure your heart rate and blood pressure.
Okay, so you will talk about the side effect, the most common side effect, loss of appetite, and this is normal. This is normal, the loss of the side effect, loss of appetite. Number one. Number two, that do not give the medication at night. Okay.
Yes, before
Do
2
not,
or 4 o'clock.
yes, to avoid the insomnia, and for the weight loss, heart rate, blood pressure, and etc. It's very important to review, to have a appointment with your doctor on regular basis, every 2 or 3 months, is to evaluate the situation and the response of the medication, and etc. If you have 1 or 2 points to say, this would be the right thing to say. Okay, that's it. So usually when we give a counseling to any patient, we focus about the side effect and how to manage the side effect or how to avoid the side effect, and the duration of treatment, how to use it, and duration of treatment or the expected effectiveness, and how to use it, or how to take it. We call it usually ETA. E for efficacy, T for tolerability, A for adherence or adherence, how to take it. Okay, ETA. This is the main points to give a counseling on. Okay, efficacy, tolerability, and adherence. That's it. Okay, perfect. In the CTC, I think you will have a table of all the side effect, common side effect, and how to manage them. But here we have 3 signs, like illustrated here. We have the red flag that you should stop the medication. Okay, this is number one. You have the little yellow light that you can stop the medication for a while and retake it again, or retitrate it in a lower dose. And you have the green light. That means the side effects are no problem and you can continue to take the medication. Okay, we have 3 types of side effects: the red ones, the yellow ones, and the green ones. Okay, are you aware about them?
Yes.
When to stop, when to continue, and when to retitrate. Okay, so okay, you will find them written here and in the CTC and everywhere. Transit continue when it's about sleeping, appetite, or weight. Weight less than 10%, okay? If the weight loss is less than 10%, you can continue take the neurostimulant with no problem, okay? When to stop it? If the patient make zombie-like movement, this is very serious and he has to stop it. And if the patient develop like psychotic symptoms or signs like hallucination and etc. This is very important as well. Should we stop it gradually or should we stop it abruptly? Let's say the patient is taking 60 milligram Vivans and he start to hallucinate. What would you do? Stop abruptly? He takes a high dose.
I think we should taper it down.
Okay, we should taper rice with 60 milligrams. Yes, when the patient is hallucinating and he's taking a high dose of neurostimulant, you should stop it abruptly. You must stop it abruptly. Okay? No need to taper down here. Because this is a serious, it's red. When it's red, so you have to stop. Okay? That's it. Zombie-like movement, hallucination, psychotics, severe depressive mode, severe suicidal attempts or something. No, here you have to stop. Okay, no need to tap her at all, just to stop. Okay, let's say that, is it okay to feel headache and loss of appetite and weight but not exceeding? Yes, Mohamed Wali is asking. Yes, headache is very common. Yes, it's very common. Loss of appetite, yes, sure, as we say, and weight not exceeding 10%. Yes, all of those side effects, Wali, Mohamed Wali, are common with the neurostimulant. Okay. Okay, one moment, guys. I will be back in 30 seconds. One moment. Yes, okay. We are back. So it's clear, right? Stop and retitrate. Yes, we have here the symptoms. That means the signs of the overdose. If you have a patient with signs of overdose, like glassy eyes, insomnia, and cardiovascular problem, tics, and something, you can stop it and retitrate the medication from the beginning, okay, with lower dose. And you can make a prolonged titration. That means he can stay with the same dose for 10 days instead of 1 week, for example. You can give him for 10 or 14 days with the same dose, like a prolonged titration, as we say. Okay. Yes.
ومعلش in zombie effect hold and reassess reassess ديت اللي هو اعمل ايه يعني؟
توديه للدكتور. Refer him to the physician.
Okay.
Refer him to the physician. So he can change the medication or prescribe any other medication.
يعني reassess هنا ان هو هيحوله لكلاس تاني مثلا او دواء تاني.
It's assessment according to the assessment. Yes, the medical judgment. Okay, perfect. We have a case scenario here. Patient has been taking Concerta 72 milligrams, which is high dose. He's taken 54 milligrams and 27 milligrams for 4 years now. Started recently to develop insomnia, difficulty in movement, and nervosity or nervousness or irritability. What could be the reason in your perspective? What do you think? It's been like 4 years that he's taken the same dose, and recently he started to develop some symptoms. What would you ask the patient for?
We can ask him if he have a change his time of taking the medication, any change in lifestyle that could affect the dose.
Like what? What kind of lifestyle can affect the dose?
Like, for instance, changing his sleeping pattern, changing timing, sleeping. Maybe he's doing some extra exercise at night.
Yes, but what signs? What do you think these signs are relevant to, or related to what? Insomnia, difficulty in movement, and nervosity, irritability.
إن هو
Is
ممكن
this
يكون
normal?
يغير ميعاد الدواء، ممكن بدأ ياخده متأخر شوية فعمل له انسومينا، فده أثر على كل حاجة بقى.
No, it's not that reason. No, he's taken the same way because it's taken the same medication for the 4 years, so everything is okay. Okay, everything is okay regarding the way of administration and the time of administration and etc.
What if he's taking a new medication? It could lead to drug-drug interaction?
Yes, this could be a reason. This is number one. Yes, we have so many reasons, my friends. Okay, it could be a drug interaction. Okay, it could be as Tantawi, I think, said, Tantawi, yes, said because of the lifestyle. Yes, it could be because of the lifestyle. Okay, it could be because of the weight loss. What do you think? Can the weight loss cause an overdosage symptom? What do you think? Yes, Leah said yes. Weight loss. And this is the most common reason from my perspective. Okay, I witnessed 2 patients who started to develop symptoms of overdosage. And when I'm asking them about the weight loss, they say, yes, I lost weight about 30 pounds during the last 3 months or something because of the diet, because of dietary regimen or something. So 2 patients were the same reason. For the same reason, they start to develop overdosage symptom, insomnia, irritation, nervosity, and some difficulty in movement and etc. Okay, so the weight loss can largely affect the response of the medication in the neurostimulant. Tamam? Clear? Okay. Let's proceed. The atomoxetine, as we said, norepinephrine reuptake, it takes 6 to 12 weeks of treatment, on contrast to the neurostimulant, which are taken around 4 weeks to give the full effect. And atomoxetine, as we said, it's the preferred agent in adults. Why? Why can we say that? Why we prioritize the atomoxetine in adults? No reason, no comment. Yes, yes, because usually, it's not always, but usually in when the patient started to have a recent diagnosis with ADHD in his adulthood, most likely he would have another psychiatric problem like an anxiety or depression or whatever. Okay, so that's why atomoxetine usually is preferred in adults. Okay, and as well to avoid for substance abuse, because when you yes, it's atomoxetine usually it's less addictive than the neurostimulant. There is no risk of addiction or dependence of on atomoxetine rather than the neurostimulant. This could be another reason as well. Okay. First line was patient who have substance abuse or depression. Dosage calculated according to the weight of the patient. Yes.
preferred agent in الادلت تفرق عن الفيرست لاين؟ يعني هنا preferred agent in الادلت ولا هو first line of in الادلت؟ هل تفرق؟
Atomoxetine is first line usually.
يعني preferred ديت مش فارقة، يعني هو الفيرست لاين.
In adult population, yes, we would prefer it, yes.
Okay.
We would prefer it, yes. As according to, we just check this. Here it is. Okay, this is this algorithm. It explains the ADHD in adults. Okay. If no risk of substance abuse, no depression, we will give atomoxetine. Excuse me, if risk of depression or atomoxetine, if risk of substance abuse or depression, we can give atomoxetine. Okay, depression, we can go with bupropion first. Okay, for depression, you can start with bupropion. If the main reason of the ADHD and loss of concentration is the depression or the low mode, yes, you can give. And the atomoxetine should be privileged here as well. But you can give, at the end of the day, you can give the neurostimulant as well, right? But there is a less risk of dependence and addiction on that. Perfect. If a patient has taken NFC, will they, okay, no problem. On what parameters we adjust the dose or choose? I think we answered that. Yes. Do you know the contraindication for atomoxetine? You know them, right? Okay, contraindication to atomoxetine, my friend. Hypersensitivity or allergy, narrow angle glaucoma, yes. History of severe cardiac or vascular disorder, pheochromocytoma, concurrent use of MAO inhibitor. Most of them are related to the norepinephrine effect of the atomoxetine. Okay, cardiac problem, vascular problem, pheochromocytoma, and current use of MAO inhibitors, etc. All of them are, and even narrow angle glaucoma, all of them are related to the norepinephrine secretion or norepinephrine adrenergic effect of the atomoxetine. Okay, these are the contraindication to the atomoxetine.
بالمناسبة هي الكونترا انديكيشن برضه للستيمولانت برضه نفسهم.
Yes, sure. طبعا. Okay. Here we have, yes, النوت دي مهمة. This note is very important. I think it's important. It's about the methylphenidate and amphetamine risk of the psychosis, the new development of risk of development of psychosis development, excuse me, in adult population. Okay. Same have both medications, methylphenidate and amphetamine, have the risk of developing psychosis in adult population. Okay, but it seems that the methylphenidate, excuse me, it seems that the amphetamine is the risk of has a higher risk of developing psychosis, new onset psychosis in adult population. Okay, adult and adolescents have higher risk to develop new onset psychosis than children. Amphetamine seems to be more involved. Okay, it's only a note. Just keep it in mind. It's only a note. It's written in the CTC. Okay, and it's interesting actually. Yes, we say that. Perfect. Here we have the antidepressants. What do you think? Antidepressants are first or second line of treatment?
Second line.
Second line of treatment, yes. Bupropion, norepinephrine and dopamine, venlafaxine, norepinephrine and reuptake. And norepinephrine reuptake. Okay, these are the preferred agent or antidepressant in ADHD. We have here important notes. Bupropion tabs, except the XR. Single dose should not increase above the 150. If you have, you know, the bupropion, we have how many forms of bupropion in the market? We have the SR and we have the XR, right? Right? صح ولا إيه؟ Yes, for the XR, it's only once daily. For the SR, it's twice daily. Which one we use for in smoking cessation? Which one we use? Yes, Hind Ayad, SR. In smoking cessation, we use the SR. In depression, we use the XR. With the SR form, the single dose should not increase 150, should not go above 150 in a single dose. Okay. Risk of seizures with bupropion increases if daily dose is above 300 milligrams. Okay. As we know, bupropion can cause seizures or convulsion. Above 300 milligrams, the risk is higher. Okay. These are important notes about the bupropion. What are the most common side effects with bupropion? Side effects with bupropion. Weight loss, not bulimia, but yes, weight loss, loss of appetite. Yes, what else? What else?
I think dry mouth.
Yes, dry mouth. Perfect. Constipation or diarrhea? It causes constipation or diarrhea? Constipation, constipation, Leah. It causes constipation, bupropion. Right? Okay.
Yes, constipation and the dry mouth, the most common side effect.
Yes. For venlafaxine, maximum dose usually is 375 milligrams. Risk of hypertension starts with the dose of 225 and above. Norepinephrine reuptake inhibition happens in dose of 150 milligrams. This is for venlafaxine. Okay, we have here some notes. Okay, so let's proceed. Antipsychotics, usually we use risperidone, and it's third line of treatment, and we use it only for augmentation in some resistant cases or to relieve the hyperactivity, impulsivity, of the patients, usually for the behavior. Okay, we use it to adapt or to treat the behavior abnormalities. Okay, it's not for the, it's not usually for the inattention or something, but we can use it like augmentor or augmenting medication, like adjuvant therapy. Perfect. We have here the alpha 2 agonist, and they are important in ADHD. Why they are important? Why? When can we use them?
عشان لو develop tics ممكن استخدم الكلونيدين، لو develop hypertension ممكن استخدم الكلونيدين. الجوانفاسين مفضل عنه شوية عشان السايد افكت بتاع الكلونيدين.
Yes, clonidine, yes. We use them usually in the, for, yes, for treatment of the tics. If the patient develop tics, yes, we can use them. And can we use them as a monotherapy in the ADHD? Can we use them as a monotherapy? Samar Kassab says no. Okay, we should.
No, it's يعني combination مع ال.
No, we can use them as monotherapy. Okay, if the patient is not tolerating the neurostimulant or the atomoxetine or any other thing, yes, you can try with the clonidine and guanfacine. By the way, are they second, first, or third line of treatment?
It's second.
They are second line of treatment? Okay, both, right? Latifa says second and third. Why? What do you mean? What do you mean, Latif? I mean second. Second and third. Okay, so you mean second? Okay, they are not third. Okay. Clonidine is third line of treatment. Guanfacine is second line of treatment. Yes, Yalia, exactly. Guanfacine is second. Clonidine is third line of treatment. Okay? That's why guanfacine is most commonly prescribed than the clonidine because of the side effects, as Noha said. Sohan said because it's more selective, so it will give less side effect profile than the other one. Okay, that's it. Good, very good. I have a question here. What is it? I cannot see. Why I cannot see it? Ah, yes. So, yes, we can use clonidine and guanfacine as monotherapy in ADHD patient. If the patient is not tolerating the neurostimulant, the other case, if the patient developed psychosis, with any neurostimulant, like with amphetamine or methylphenidate. So here we privilege or we prioritize the non-stimulant options. What do we mean by the non-stimulant options? We mean the alpha 2 agonist, we mean the antidepressant, okay, and we even can mean we may mean the antipsychotic like the risperidone. Okay, if the patient has contraindication or is not tolerating the stimulant, you can give any other thing like the psychosis, or if the patient develops psychosis or whatever. Tamam? Tamam. Okay, for this type of medications, is there some references for all the first, second, and third line of treatment altogether? Yes, in the CTC, Amgad, you will find them. You will find them in the CTC. Look, the first line of treatment for ADHD, they are the long-acting neurostimulant. Okay, they are the first line, and that's it. For the second line, as we said, antidepressants are second line, clonidine third line, guanfacine second line, atomoxetine first line. That's it. It's very easy to remember. Okay, let's address this question. What may happen if you would stop the medication abruptly? How to stop? What do you think? Is there's any risk if we stop the medication abruptly? Clonidine or guanfacine? Both of them? There's any problem? Rebound what? Hypotension.
Rebound hypertension.
Hypo or hypertension?
Hyper.
Yes. Yes. Rebound hypertension can happen. Okay? They may cause hypertension crisis. Hypertension crisis. So it's very serious. Do not stop them abruptly. Do tapering over 3 or 4 weeks. Just decrease 1 milligram per week. I think for guanfacine, we decrease 1 milligram every 4 to 7 days. 1 milligram every 4 to 7 days, we decrease the dose for the guanfacine. Okay? If we stop them abruptly, we will get hypertensive crisis. Okay, drug holidays. What do you mean by drug holidays? In summertime, we may decrease or stop, we may decrease the dose for 2 to 3 weeks just to make like an assessment how the patient is doing, how is behaving. Okay, if we decrease the dose. Okay, usually we do not stop the dose. We do not stop the medication. We keep the medication in a lower dose. And we can do it as well in the weekends. On the weekends, we can do the same thing. Okay, and it's common, by the way. You find so many patients, so many children with 2 concentration. 1 concentration in the school time and lower concentration in the vacations and the weekends. Okay, so it's common. Okay, but can we stop the medication? Can we make a drug holiday with no neurostimulant, without giving any neurostimulant? Can we do it? And in what cases? Can we do it? Can we stop the medication completely for 2 to 3 weeks, or even 1 to 2 months, or even in the weekends? Yes,
No, I
Leah.
think
Go ahead.
no, كنت هقول لأ فطلعت
Yes.
مش صح.
No, yes, we can stop it. We can stop the neurostimulants for a certain time, for a certain period. Yes. Okay, sure thing. That's بالظبط كده. هي دي الأجازات يا عم أمجد. Yes. For what, in what cases, in what situations we can stop it?
في ايه 6 days
Okay, I will leave you to I will leave you for 30 seconds. I have to take this phone and just think about that. I will be back. Okay, 30 seconds. Yes, my friends. Do we have any answer here? Is there a good response? The doctor
Not severe case.
decide to give a drug holiday in summer.
I think if it's not severe case, we can make holiday, and if I want to decrease the side effect, I can give holiday.
Okay, yeah, something alike. Okay, okay. When we can give drug holiday in two situations. Okay, first when the, as you said, when the patient experience like a side effect that we can stop, like if he lost his weight for more than 10%. Okay, if he has a weight loss or like an effect on his growth, so we can stop the medication for certain period of time, like for the vacation time or for the summertime and etc., to alleviate the side effect of weight loss or the gross impact. Okay, this is the first situation. Second situation, if the doctor, as you said as well, I think one of you said, if the doctor would like to say, this kid has been taking the medication for a long period, so now it's time to say, to witness like what we call continued effect. Continued effect. If the patient is taking the medication for 10 years, for example, and he should be totally dependent on it, and his behavior is well disciplined now, for example, he's not making any trouble, he's well behaved, he's adult, he's mature enough, so we can make the decision to stop it for 2 to 3 months to verify what we call continued effect of the medication. Okay, so in that case, yes, we can do it. So we can do it to stop the effect on the growth or in the on the weight loss, or to see the continued benefit of the medication, of to make a decision if we, can we stop it permanently or no. You got what I mean? Usually these are the two situations. Okay, so here we talked about the drug holidays. Let's proceed. We are almost done. Patient is taking amphetamine. It causes him problem and side effect. The doctor decided to change it to atomoxetine. Yes, if a patient is taking amphetamine and the doctor decided to switch him to atomoxetine, what approach we will follow? What technique? What technique we can follow? The technique we follow here. Do you remember the duration of action for the atomoxetine? The duration of the...
We're gonna taper the stimulant and augment with the atomoxetine.
Yes. Slowly, over how long? Do you remember the period of time? Atomoxetine give effect after what time? After how long?
6 to 12 weeks.
Yes. Yes, 6 to 12 weeks to start to give the full effect. Okay. So what we do here, usually, we continue giving the neurostimulant in a lower dose for almost 3 to 4 weeks till the atomoxetine kicks on and kicks off and kicks in, I think you see. Yes, kicks in and start to give effect. Okay, so usually we continue giving the amphetamine for a duration of treatment of for duration of 3 to 4 weeks in a lower dose till the atomoxetine starts to give his full effect. Okay, this is the technique. Okay, and it's the same thing for methylphenidate as well, atomoxetine or methylphenidate. This is the switching issue. Yes. Do you remember the schedule of the Concerta? It's here. It's here. Dose conversion of from methylphenidate to Concerta. Many of you have asked me about that. Okay. So here you have the table. It's a conversion table. Okay. Just read it. Perfect. We have a question here, and it's an important one. What about the use of stimulant in pregnancy? In pregnancy, can we use the stimulants or no? What do you think? Can we use them or no? Leah says no. Yes. Any other answer? Yes or no? Can we use them or no? Stimulants. Stimulants. Can we use them or no? Latifa, yes, we will share you the material here for the table and all everything you will have. Hindayed says yes, yes, thanks. Okay, perfect. Yes, we can use the neurostimulant, my friends. Okay, so I will tell you what we do. In pregnancy, for the less dexamphetamine, mixed salt amphetamine, methylphenidate, we can give them in pregnancy. Okay, no problem. So less dexamphetamine, methylphenidate, mixed salt amphetamine, we can give them in pregnancy. For dextroamphetamine, there is no evidence. We have no evidence. So it's not preferred, dextroamphetamine. And for atomoxetine, we avoid. We avoid the atomoxetine in pregnancy. Okay? And the same thing in breastfeeding. I believe they are the same thing. Okay? Perfect. Noha is saying but. But for what? But. Yes, Noha. Do you have any comment, Noha? Methylphenidate not in pregnancy? I think yes, you are right. Yes, yes, yes. It's risk. Yes, there is a little risk of cardiac malformation. Yes, correct. Perfect. صح. Perfect. Yes. Methylphenidate, yes, constitutes risk of cardiac malformation, especially during the first trimester. Yes, this is correct. So dextroamphetamine, no evidence. Methylphenidate, better to avoid. It's not contraindicated, but better to avoid. Okay. And let's check the CTC. I think yes, it's here in the CTC. I highlighted it. Yes, here it is. It also found that methylphenidate was not associated with the risk of major malformation, appears to be associated with elevated risk of cardiac. The clinical significance. Caution is advised with the use of methylphenidate during the first. Yes, as we say. So methylphenidate better to avoid, but it's not contraindicated, especially during the first trimester. Okay, but for the others, everything is okay. For the dextroamphetamine, use of dextro during pregnancy was not associated with increased risk. Okay. So حتى even the dextroamphetamine, it seems yes. Okay, perfect. So let's stick to that, my friends. Let's stick to what's written here in the CTC. So the neurostimulants we can give, what caution should be attempt should be followed with methylphenidate. Methylphenidate, better to avoid during the first trimester. But yes, we can give it in pregnancy as well. Okay. Atomoxetine, as we said, should be avoided. Okay. The only one should be avoided, the atomoxetine. Methylphenidate, there is a precaution on it. Okay. Perfect. Yes, dietary consideration, they are basic molecules. So if you give them with acid like vitamin C, Coca-Cola, alcohol, the absorption will be decreased. While if you give them with alkaline or alkali, you like sodium bicarbonate, their absorption will be increased. Okay, that's it. What about the natural health product in ADHD? Here is a table, guys. Table with all the medications with the neurostimulants, and you will find here, is it a capsule or tablet, duration of treatment, okay, starting dose, release, and etc. Dose titration, and etc. Okay, here you will find everything here in the neurostimulant. Okay, perfect. That's it. Okay, this is the last thing. Natural health product in ADHD. Usually we give medications. We have no strong evidence on natural health products in ADHD, but usually we can give the medication that can sedate or hypnotize or act like anxiolytics. Okay, like the chamomile, like the omega-3, like even ginkgo biloba, I think we can give it, prime rose, and etc. You will find them all written in the CTC. Okay, that's it. Melatonin, طبعا melatonin. That's it. And I think we have everything that we had to say. In season 2, you will find some questions. You will find the presentation as well. You will find some cases and the questions on the CTs, on the ADHD. Okay. Here it is. We will upload all these questions in a question bank. Okay, we are working on that. As we said, you will find a question bank in the CTC. I can't find season 2. I didn't attend season 2. Yes, we will re-upload them again. Sorry, our colleague Shams removed them, but no, we will re-upload everything again. You will find season 2 till we are done with the question bank. Okay? You will find the question bank with answers and with explanation to every answer. Okay? Any questions on the ADHD?
Doctor, please, I have one question.
Yes.
Okay. To summary up two things. First of all, for all the medication, we can open and sprinkle it over water or juice, except the concerta. I am right?
Yes, we can say that.
Okay. The other thing, it is if the medication given less than 3 months, we can discontinue it without tapering. I am right?
Yes, it's written in the CTC as well. Yes.
Okay. That's it.
مظبوط
Thank you.
كلامك.
Okay.
Okay, my friends. An anxiety disorder. Let's take 1 or 2 minute break. Okay. Okay, we will take 1 or 2 minute break. Okay, we will be back. I will stop the recording here.